Okay, let's talk about acute compartment syndrome. Seriously, if there's one topic you absolutely have to know inside and out for your final exams, this is it. It's that perfect storm of high-stakes medicine and critical split-second decisions. And look, mastering this stuff, it's not just about getting that passing grade. It's about protecting your patients from some truly devastating, life-altering outcomes. So let's dive right in.
And let's just get this out of the way right from the start. This quote says it all, doesn't it? Why does this matter so much? Because a misdiagnosis isn't some small mistake. We're talking devastating, permanent problems for the patient. And, to be frank, it's a huge source of litigation. The bottom line is, this is one of those things we absolutely have to get right every single time.
So, here's our game plan. First, we'll define what this emergency is and who's really at risk. Then we'll get into the how and why, the pathophysiology, which I like to call the pressure cooker effect. After that, we'll cover how to spot the subtle signs, how to confirm what you're suspecting, and what to do immediately. And finally, we'll tackle that classic exam day curveball, the whole debate around a regional anesthesia. Right then, section 1. What are we actually talking about when we say acute compartment syndrome? And maybe more importantly, which patients walking through the door should have alarm bells ringing in your head? So here's the formal definition, and trust me, every single word here matters. You've got this closed, inelastic compartment. The best way to picture it? Think of a super rigid box where the walls are made of fascia and bone. Now, when something causes swelling inside that box, the pressure just starts to build and build. It gets so high that it literally starts to squeeze the blood vessels shut. And when that happens, circulation gets cut off, and all the tissues inside, the muscles, the nerves, they start to suffocate. Now, you might see this number, 3.1 per 100,000, and think, okay, that's pretty rare. And you'd be right for the general population. But, and this is a huge but, in certain groups of patients, that risk just goes through the roof. So who are we watching like a hawk? Well, the textbook case is a young guy, under 35, who comes in with a tibial shaft fracture, a broken shin bone. In fact, these fractures are the culprit in up to 40% of all cases. You add in things like high-energy trauma, a nasty crush injury, or the fact that the patient is on anticoagulants, your suspicion level should be at a 10 out of 10 from the get-go. Okay, so how does this actually happen? Let's get into the mechanics of it. To really get it, just imagine a pressure cooker. You've sealed the lid, you turn up the heat, things inside start to expand, and that pressure has absolutely nowhere to go. It just keeps climbing. That's exactly what's happening inside the limb. In this image right here, this is our pressure cooker. It's a cross-section of the lower leg. You can clearly see these separate compartments, all tightly wrapped in this tough, leathery fascia that just does not stretch. And packed inside are all the important bits, muscles, nerves, and blood vessels. When swelling starts, they're trapped. And this kicks off a truly vicious cycle. It's a downward spiral. First, the injury causes swelling and the pressure goes up. It gets high enough to squash the veins, so blood can't get out. Well, now the pressure gets even higher, which means fresh blood can't get in. The tissues become starved of oxygen. And what do oxygen-starved capillaries do? They leak. They pour even more fluid into this already overstuffed compartment, which, you guessed it, cranks the pressure up even more. This whole nightmare can cause permanent damage in just a few hours. So, what kicks this whole thing off? Obviously, trauma is the big one. Fractures, crush injuries, burns. But for us, as anesthesists, the iatrogenic causes are absolutely critical to know. We're talking about a patient who's been in the lithotomy position for a really long surgery, or an IV drip that's tissued and is pumping fluid into the compartment. These are things that happen on our watch. It can even be caused by someone being immobile for a long time after a drug overdose. The big takeaway here is it's not just for the trauma team. This leads us to probably the biggest challenge, and a place where they love to trip you up in exams. Actually diagnosing it. How do you pick it up? Because the classic signs that we all memorized, they're often late to the party, and honestly, not that reliable. Ah, yes, the good old 6 Ps. We all learned them. But here is the most important thing to burn into your brain. If you are waiting for pulselessness or paralysis to make your diagnosis, you have already lost. The limb is probably toast. By the time the pressure is high enough to cut off the arterial pulse, the muscles and nerves have been dying for hours. These aren't early warning signs. They're signs of a full-blown catastrophe. So if we can't rely on those classic signs, what do we look for? What's the one thing, the single most sensitive clue that should scream compartment syndrome long before any permanent damage is done? This, right here, pain out of proportion. This is the cardinal sign. It's the patient with a simple fracture who is writhing in agony, needing more and more morphine. It's the pain that just doesn't make sense for the injury. Another huge one is pain on passive stretch. So if you gently stretch the muscles in that compartment and they cry out in pain, that's a massive red flag. If you remember one thing from this whole explainer, make it this. So clinical suspicion is king. But what about the patient who can't tell you they're in pain? Maybe they're intubated in the ICU or they have an altered mental state. In those tricky cases, we have to go beyond suspicion and get an objective number. When you stick a needle in there to measure the pressure, there are two numbers to think about. For a long time, people just used an absolute pressure, anything over 30 mmHg as the cutoff. But a much better and more accepted way to think about it is the differential pressure. You take the patient's diastolic blood pressure and subtract the compartment pressure. If that number, which is basically the limb's perfusion pressure, is less than 30, that's your trigger for the surgeons to intervene. It just makes more sense because it takes the patient's own blood pressure into account.
All right, so you've made the call. You either strongly suspect it or you've confirmed it with a pressure reading. Now what? Well, now the clock is ticking loud. This is a true surgical emergency. While you're getting the surgeons on board, there are two incredibly simple but vital things you need to do right now. First, get the scissors and cut everything off. Bandages, dressings, casts, anything that's squeezing the limb needs to come off completely. Second, get the limb level with the heart. A really common mistake is to elevate the leg to try and reduce the swelling. Don't do it. All that does is make it harder for arterial blood to get in, which makes the ischemia even worse. Keep it. The only thing that truly fixes this is surgery. It's called a fasciotomy. The surgeon makes these long cuts through the skin, and most importantly, through that tough, unyielding fascia. And look at this picture. You can see the muscle literally bulging out. It just shows you the insane amount of pressure that was trapped in there. This is the only way to get the blood flowing again and save the limb. And that brings us to our final section. The one topic that's pretty much guaranteed to come up in your exams and has been the source of arguments between anesthetists and surgeons for years. What's the deal with regional anesthesia in patients who are at risk? I love this quote because it just perfectly sums up the historic battlefield. The surgeons worry, quite reasonably, that if we put in a great nerve block, we're going to mask the number one sign, that pain out of proportion, and cause a delay in diagnosis. We, on the other hand, argue that letting a patient suffer in agony is just not acceptable. So, who's right? Well, thankfully, the 2021 guidelines have given us a really clear, evidence-based path forward. The consensus is, yes, we provide analgesia. It's a basic human right. But, and this is a big but, we do it intelligently. The old way of just throwing in a dense, long-acting block that completely numbs the limb for hours, that's out. Instead, we're using smarter techniques. Think single-shot blocks or even continuous catheters, but with really low concentrations of local anesthetic. This gives the patient fantastic pain relief, but it doesn't totally wipe out their sensation. It leaves the door open for them to feel that telltale breakthrough pain. And the best part? The evidence is pretty clear. When you do it this way, and you make sure there's proper monitoring on the ward, the diagnosis is not delayed. So really, the final question is this. Can we have our cake and eat it too? Can we give our patients the amazing pain relief they deserve while still keeping them safe? The modern answer, backed by good evidence and smart techniques, is a resounding yes. We absolutely can. All the information we've gone through today comes from some fantastic papers, particularly those 2021 guidelines published in Anaesthesia. I definitely recommend you read them yourself for an even deeper dive. Thanks for listening.